here in Northern Michigan through Munson Healthcare. Next slide, please. Joining us today is Dr. Gary Rajah, cerebrovascular neurosurgeon and director of the endovascular stroke program for Munson Healthcare. Dr. David Rosenbaum-HaLevi, interventional neuroradiology and neurology for Munson Healthcare. And I'm Brian Lawson. I'll be your facilitator today. I want to remind you to please pass along your questions. If you're joining us from Facebook, you can submit those questions through the comments section. And if you're joining us via Zoom, please use the Q&A function. We'll have both of our panelists on at the end of the presentations for a quick Q&A. Next slide, please. We're going to begin by looking at the impact of stroke, different types of stroke, how to identify them, and what to do if someone is having a stroke. Joining us now is Dr. David Rosenbaum-HaLevi, board certified in neurology and fellowship trained in vascular neurology and interventional neuroradiology. We are pleased and very fortunate to have someone of his skill here in Northern Michigan, equally grateful to have him join us now. Dr. Rosenbaum-HaLevi, you have the floor.
All right, thank you very much, Brian. Good to be here. Everyone's doing well. So we're just going to take a couple minutes and talk about stroke in general, ways to avoid it, things to consider when one is concerned that they're observing a stroke in real time. So a bit of a background. The most important thing to remember that what does a stroke mean? A stroke is injury to the brain. The brain is very sensitive and time is of the essence. So keep in mind, it's the 5th leading cause of death among adults. It's a leading cause of long-term disability, very frequent, every 40 seconds in the United States, someone can be having a stroke, and that amounts to about 800,000 people per year in the US. The good news is that a large majority of the strokes, close to about 80%, are preventable, and we'll talk about that in a minute. Next slide, please. So what is a stroke? Stroke, for the first part of strokes that we're going to be talking about here, these are ischemic strokes. This means that there's a sudden loss of blood to the brain. It can be a complete loss or a partial loss. When the brain doesn't get blood, it's not getting oxygen because the blood is what carries the oxygen to the brain. Without oxygen, the brain can't breathe, and that's what causes the brain damage. Next slide, please. So there are many parts of the brain. So just talk a minute about the forebrain. That's the largest part of the brain. That's where most of our cognitive processing goes on, our thinking, decision-making, planning, and personality, who we are as people. Those areas of the brain are compartmentalized there. Every minute of interrupted blood loss loses about 2 million neurons. So you look at 22 billion, every minute is 2 million. So you're not losing everything at once, but over time that can accumulate to be a significant injury. So keep in mind, an hour of interrupted blood supply is roughly equivalent to about 3.5 years of normal aging. Next slide, please. So we spoke about ischemic strokes, which are blockage of blood vessels where the blood is not going to the brain. That's the large majority of stroke when we're talking about stroke, about close to 90%. There are different types of blockages. One could be a blockage where there's a clot that goes and blocks the blood vessel. Another could be where the blood vessel itself stenoses and shuts itself down. Then the other type of stroke to consider is the bleeding etiology, where it's not that there's a blockage, but rather one of the blood vessels or the arteries in the brain ruptures from their number of reasons that can happen. And that causes blood to accumulate in an area of the brain that pushes pressure on the brain and causes damage anywhere around that bleeding occurs. That's about 13% of strokes. Next slide, please. So what's a TIA? That's a term that we hear a lot about in the television and the media. And it's very important to recognize these because these can often be a precursor to a bigger stroke, and it also increases the risk of stroke, of a big stroke, by about 10 times. So a TIA is when you have a transient loss of blood to the brain, where you can have little tiny clot that opens up, or the blood vessel that shuts down momentarily and then reopens up. They're usually less than a few minutes, but symptoms can last up to 24 hours and then resolve, and then they'd still be considered a TIA. Usually the patients don't undergo any pain, but it's typically associated with some kind of neurologic deficit. That can be a vision deficit, weakness, speech, and we'll talk about that more. Next slide, please. So what's important is to be fast. That's our mnemonic, BEFAST. Stroke is a brain attack, and the faster you are at getting to the hospital, the better it is. You know, a lot of patients, I hear stories that they're very unfortunate, where someone is having stroke-like symptoms and they say, you know what, let me give it some time, this will go away. Let me go to bed, maybe it'll go away in the morning. And then very often it's too late. So it's important to be very sensitive to these things and take them very seriously. Worst case scenario, you get seen in the emergency room and sent home. The alternative of not coming on time can be very severe. Within 3 hours is usually what we consider a key cutoff time, because there are a lot of medications that the earlier we can administer them, the better off it is. So again, just to reiterate that point, be fast. Next slide, please. So what does be fast stand for? BE. So these are types of strokes that affect the posterior part of the brain to a large degree. These are changes, sudden changes in balance, dizziness, nausea, vomiting. Eyes is E, loss of vision or double vision. F is face, so drooping of the face or difficulty chewing. Usually this will be on one side of the face, and the other side of the face will be normal. So it's important, typically people who have family members who recognize, you know, some people have a little bit asymmetry in their face, but if someone you know well, to be mindful. A is for arms or weakness to one side of the body in particular. S is speech, and speech could be gurgled speech, speech could be slurred, or speech could be lack of understanding. And last is T. T stands for time. So if any of the BEFAS, immediately call 911. Next slide, please. Keep in mind, you know, sometimes it could be a stressful situation, but when 911 comes, one of the things they'll ask is, what time did these symptoms start? Because that's really important for us when we're making decisions, because the longer a stroke's going on, the more potential injury the brain has suffered. And then there are certain medications we can't administer if there's a certain amount of injury to the brain, certain interventions that we can and can't do. So it's important for whoever's with the patient, whether it be friends, family, coworker, to be mindful of that if they can. And then call EMS ASAP. They take the vital signs, they do a skilled physical exam, triage the symptoms if it's a stroke, and then they let us know ahead of time that the patient's coming, so we're ready to treat them as soon as they hit the door. Next slide, please. So what happens when a patient actually comes to the emergency room? They're seen immediately by a stroke team, which is a stroke specialist, as well as an emergency physician and a team of nurses. They immediately get a CT scan to evaluate, first of all, if there's any bleeding or any other cause of their symptoms. You know, sometimes stroke-like symptoms cannot be caused by a stroke, but by a tumor or a seizure. So it's important to make that diagnosis quickly. And then if they're considered a good candidate, they can be offered medication, specifically a clot-busting medication, if they're early enough and there's no signs of bleeding on their CT scan. Next slide, please. So we spoke briefly about that clot-busting medication. That's called TPA. It's given IV, and the idea is that it can dissolve a clot. It's a pretty good medication, but it has its shortcomings. And because of that, there's another option, which it's not mutually exclusive. If the patient's a candidate, we'll usually do both. And that is to actually go in and open the blood vessel. That's done intravenously or intraarterially, to be more precise. It's done in our angio suite under direct visualization. We have very high-tech equipment that allows us to do that. And sometimes patients who have blockages of the arteries, in addition to having us go in and pull that clot out, we actually have to put in stents to keep the blood vessels open. Next slide, please. So if a patient's considered a candidate, the team for the endovascular procedure is activated immediately. All members of the team have access to the imaging directly to our phones or computers, and we make those decisions already while the patient's en route, very often. Sometimes, depending on the source of the stroke, patients might need a more significant surgery, which requires opening of the skull. And we have skilled physicians, my partner, Dr. Rajah, who's able to do that if needed in an emergent setting. Next slide, please.
Thank you very much, Dr. Rosenbaum-HaLevi. We'll give you a short break here and then have you back for the Q&A.
Thank you.
Joining us now is the director of the endovascular stroke program at Munson Healthcare, a cerebrovascular neurosurgeon, fellowship trained in vascular neurology, and he came to us from the Gates Vascular Institute in Western New York. I will now hand it over to Dr. Rajah for an update on what kind of stroke care can be received through Munson Healthcare here in Northern Michigan, and more important, what you can do to prevent a stroke. Dr. Rajah.
Thank you, Brian. Thank you, David, for getting us started here. My name again is Gary, and I'll be talking to you a little bit about kind of the two types of stroke and how we treat them, and sharing two patient stories for two patients that were treated here recently and wanted to share their stories. So we've been fortunate here at Munson Medical Center that in the development of this interventional stroke program, to be able to acquire two beautiful biplane X-ray suites that we put kind of back to back with some renovation projects, and really created a state-of-the-art environment to perform these surgeries for the patients of Northern Michigan. We started about 2 years ago doing interventional stroke care, and it was at that time that we stopped having to send patients downstate because, again, in Northern Michigan, we know that there's times when helicopters can't fly, and we just, heard from David about how time matters and that these treatments are better done close to home. And so we now have two biplane suites back to back, and essentially we're able to do these procedures, and you can see a picture on the left there of what that looks like under X-ray within tiny blood vessels of the brain, reaching through essentially the wrist or the leg with catheters in a minimally invasive fashion. And it really is a game changer for patients of Northern Michigan, as I'll kind of show you here. Next slide. So being able to take care of two types of stroke, such as ischemic stroke, which is when a blood vessel is blocked off in the brain and not letting enough blood go up there, which is the more common stroke that everyone thinks of when we talk about stroke. There's the second stroke that David mentioned, which is a hemorrhagic stroke when there is bleeding in the brain. And being able to handle both bleeding in the brain and ischemic stroke is what kind of makes up comprehensive stroke care. And we've been providing this care to Northern Michigan now for about 2 years, and we are working towards third-party accreditation, which is standard as well here this year, which we are all very excited about. So a lot is changing here at the medical center and the healthcare system for Northern Michigan, and benefiting all of our patients. Next slide. So to date, just to give you some statistics of how busy we have become in such a short time, there's probably 16 to 30 different conditions that we're able to treat that were not previously treated here at Munson Healthcare with the advent of this neurovascular care. In 2 years, we've done over 500 angiograms. We've treated, over 220 emergent strokes, and we've treated over 100 aneurysms, including, many of these which are ruptured aneurysms, which contribute to hemorrhagic stroke. And in addition, we're able to do open vascular procedures as well, such as craniotomy, which means making a hole in the skull and taking out blood, or fixing vessels and removing pathology as well that way. So really, we have a full armamentarium of techniques and skills to help with all of the treatments here in Northern Michigan. Next slide. So here we have one of our patients that we would like to thank for sharing their story. Peg's case came to us as a hemorrhagic stroke from just north. And she came down and presented to the hospital and was transferred in with what we call the worst headache of her life. And this is a very common finding in hemorrhagic stroke, especially of an aneurysm type, where patients have a very severe sudden headache at the time when that blood leaks out of the weak spot and goes into the surrounding areas of the brain. And so this is a life-threatening situation. And again, time does matter in these situations, as other issues can arise, such as problems with swelling on the brain and so forth. So Peg came to us, and we triaged her appropriately using, the special equipment that we have at our at our hands, including to our cell phones, how we're able to communicate in real time with our Northern Michigan sister facilities. We were able to identify 2 areas of weakening in her blood vessel walls called aneurysms, and they kind of look like balloons. And you can see them here. One is the basilar aneurysm, which was the one that was that had leaked into the brain, and that whole area where the arrow is pointing there shouldn't be there. Essentially, it should just be 2 vessels that come up and split, and there should not be that large sac at the end. And she had another aneurysm, the left ICA terminus aneurysm, also in the same area of the blood. These 2 aneurysms were very close together, and so both actually required treatment at that time. And we were able to do her procedure, with some sedation and utilizing a small poke in the leg and catheters. We were able to go up and place these devices that block off, and you can kind of see the web device there where the arrows go. They block off the aneurysms so that they cannot bleed essentially ever again. And so this is something that helps prevent another rupture or bleeding episode that could be life-threatening and further, put the patient in a worse situation. And then the patient has to be watched very closely for, 10 to 14 days in our ICU to make sure that no other issues happen. And this is a special monitoring situation that is particular to subarachnoid hemorrhage and aneurysms, as well as hemorrhagic stroke. So next slide. We can go to the next slide. Thank you. And so this is just a picture of what blood in the brain looks like, or what we call subarachnoid hemorrhage. That arrow goes to that white spot there. And my slides may have a little delay here. And this is Peg. She really wanted her story to be known. She has returned to life with her family and enjoys traveling, and is very thankful for the care that she received here at Munson Healthcare. Next slide. And so the second case that we'll talk about today is RENEE'S case. And RENEE is what we call an ischemic stroke, a large vessel occlusion So not bleeding in the brain, but a type of stroke where there's not enough blood flow to one or both sides of the brain. This is the type of stroke that most people think about when we use the term stroke, but it is, again, a subset, the more common subset of stroke. And so in Renee's case, she came to the hospital again via transfer after waking up and experiencing complete loss of movement on one side of her body, not acting right, not being able to talk properly. Essentially, she was having a very large stroke, the type of stroke that untreated either can result in death or having to go to like a nursing facility in almost a vegetative state. And so she was able to get treatment and triage, as Dr. Rosenbaum talked about earlier, and our real-time imaging kind of went off as she came into the emergency department and showed us, kind of the status of what her brain was going through immediately at that time. And that helped us to then go ahead and make decisions as to how to immediately treat her and get her the best possible chance at a good outcome. So if you look on the screen left there, you'll see some red and green pictures set within the brain. This is some artificial intelligence software that comes immediately to our phone across northern Michigan if a patient is admitted to or brought into a Munson facility utilizing this app and with a CT scanner. And so Dr. Rosenbaum and myself are able to look at patients' images in real time while they're having these issues to help guide care and guide transfer and to make appropriate decisions, in real time. And so in Renee's case, you can see the green area of the brain, one whole side, was essentially undergoing a stroke. And the red tissue, the red area, is the amount of tissue that the computer thought may actually have already undergone an irreversible stroke. So the green is what we can potentially save, and the red is, the amount of tissue that may be damaged. And so we have to, as physicians, sort of weigh all of this information along with many other things to make the right decision at the right time, and very quickly, obviously, to then proceed to the next step. And so our other imaging suggested that Renee had a blockage not only in her neck, but also in her brain on the right side. So a double blockage, what we call a tandem blockage. And so those are very dangerous and very bad for the patient because, not only one area is blocked, but also another area on the same side. And this creates issues with getting up there and really can add time to the procedure as well when it's not just a simple clot in the head. And so the picture on the screen right just shows the intracranial vessels. You can see on the left side, which is actually screen right for you, there's vessels going out nicely, the little white lines, and on the right side of the brain or screen left, you can see that there's a missing segment of vessel as well as the missing segment below it. And so this is what happens when the carotid artery and the middle cerebral artery are occluded in a patient. Next slide. And so without wasting time, we appropriately triaged her and had her into the angio suite, essentially within minutes of her arrival. The team is already in. They have the app as well, and we communicate in real time so that we can be ready when the patient is ready to go. And at that point, we gain access to the vascular system either by using the wrist or the leg. Sometimes we have to use the wrist if the anatomy is not favorable or if patients don't have good pulses or good blood flow in their legs. And so, we make that decision as well. And that sort of leads us in the way that we select our catheters and devices to go along with the procedure. And so our rooms need to be stocked with numerous devices and catheters so that we can select the right tools for the right task for the patient. And for one stroke treatment, we may use 4 or 5 different catheters, and you're sort of working those with your 2 hands while looking at the screen in front of you. And again, remember the vessels in the brain are 1 to 2, maybe 3 millimeters in the big areas. And so, things have to be done under high magnification and obviously delicately. And so if you look at the image on screen right, you'll see this is a side view and the arrow is pointing to no blood flow in the brain. And then the blockage, which is in the neck, which is all we can see because the blockage in the brain that is also up there, you can't see without the contrast getting up there. So again, there's 2 blockages as we talked about earlier. We have to get through first the blockage in the neck, which we do with balloons and stents. And then we have to get up into the brain with catheters to snare or suck out that clot as well. And you can see that we were able to open these successfully here on the middle image. And then the image on the right just sort of shows what the vessels should look like in the brain, how small they are, how they kind of branch out over the brain. And that's what you want to see. Next slide. So again, over the course of the next 2-3 days, Renee slowly regained the ability to talk and move her arms and legs. She was able actually to be discharged home, neurologically, what we call intact, meaning essentially having no deficits from a major stroke because of the software and the teams and the expertise that we've been able to acquire at Munson Healthcare over the last 2 years to treat these devastating conditions. And so, she was obviously very thankful for the team and wanted to share her remarks as well, period. Next slide. And so that concludes our cases, but I'll just leave you with a few more slides here. Stroke, especially ischemic stroke or the lack of blood flow to the brain, about 80% of it can be prevented with healthy behaviors. And those are sort of what we call the primary prevention things for stroke that we talk about, especially, out in the communities. Things like lowering blood pressure, checking cholesterol, maintaining low cholesterol, being healthy and active. Next slide. On our website at Munson Healthcare, you can go to the stroke page and there's a link provided. You're able to look and evaluate your stroke risk with our Stroke Health Evaluator tool. There's also a lot of other good information on the website as far as groups, stroke groups, aneurysm groups that patients can be a part of to go sort of get more information and talk to patients also that have been through sort of the same thing. And there's also links to all of the physicians that are part of the stroke care team, as well as the other parts of the care team, which include the rehab department, physical therapy, speech language pathology. It really does take a whole village to take care of one patient in a comprehensive way. Next slide. And so on the lines of, modifiable things we can control, we can't control our genetics, but we can control things like what we eat, eating good, healthy diets, which obviously can be difficult depending on the situation, but, fruit, vegetables, whole grains, fiber are all good things. Decreasing the amount of sodium that we take in, the American diet is full of salt, and that's partly to blame just from preserving food and processing it and fast food and those types of things. But again, if we're cognizant of some of those things, we can help with lowering our own individual stroke risks to some degree. Next slide. And staying active. We touched on this earlier. Exercise is great. That doesn't mean you have to go run a marathon, but I think that getting up and about 30 minutes of moderate physical activity a day, getting your heart rate up, are all things that patients should talk about with their primary care physicians to come up with a plan that sort of works for them and their specific situations. High blood pressure, high cholesterol, we talked about, sugar, all things that we need checked at our primary care offices on a routine, regular basis. And obviously there's the things that we need to avoid. Tobacco use, whether that's smoking, chewing, vaping, has over and over been linked to not only aneurysms and brain bleeding, but also to ischemic stroke and numerous other medical issues that can affect the heart and brain, as well as to worse outcomes, not only to having the issue, but then having possibly a worse outcome because of tobacco use. So, again, it's something that is what we call modifiable. There are programs, there are numerous smoking cessation pamphlets and ideas to help, either through primary care offices or through the Munson stroke page online. But that is a very modifiable risk factor. And then alcohol intake, everything in moderation. And so, avoid binge drinking, avoid heavy drinking, those types of things do help with stroke prevention. Next slide. And so, I think we're wrapping up here. Some important takeaways. Stroke is a brain injury that arises when blood vessels are either blocked or they're burst. So when a blood vessel bursts and there's bleeding in the brain, that is a hemorrhagic stroke. When a blood vessel is blocked, that is an ischemic stroke, which is the more common type of stroke. And then these two are not in their own silos. They can be related to one another, whereas you can have both issues going on at the same time. And so stroke is a very complicated disease. And, when you suspect that someone is having a stroke, if they're having the worst headache of their life, or if they're having the stroke symptoms that Dr. Rosenbaum talked about with the BFAST, you need to call 911, remember time is brain, and get to medical attention immediately. We've talked about the immediate treatments and the things we've done here in Northern Michigan to create this stroke net for, visitors, for people who live here, for people who are passing through within the northern part of the state. 80% of strokes are preventable, and living a healthy lifestyle goes a long ways. Thank you everyone for your time, and I'll turn it back over to Brian.
Thank you very much, Dr. Rajah. And we'll bring in Dr. Rosenbaum-HaLevi again to answer a few questions that we've received during the presentations. I'll start with you, Dr. Rajah, and going back to prevention for just a second. Is aspirin recommended to prevent a stroke if you've either had one or are at risk for one?
Yeah, I think that's that question is in some ways very common. But the other part of it is that it kind of really depends on the situation and kind of what's going on with the patient overall, because some people can't tolerate an aspirin. So I think that's a very specific question, and I hate to answer it in a way that would be broadly generalized. Dr. Rosenbaum, thoughts on that?
I think I agree with your response, because aspirin does affect the clotting of the blood, and not everybody should be on a medication that can affect their blood clotting. In a generalized sense, that's probably true, right? In generalized, assuming the patient doesn't have any risk factors, we would put a patient on an aspirin if they're at high risk, or certainly a baby aspirin if they're at high risk or have had a previous stroke. That's fairly standard of care, but it would need to be a decision made by a medical professional who could just make sure that the patient is appropriate for that intervention.
Dr. Rosenbaum-HaLevi, why is it difficult for some victims to identify the symptoms of the stroke? Is it a subtleness, or is it often a denial that it's actually happening?
I think it's a combination. I think that sometimes stroke symptoms are subtle, as you had mentioned. It could be just a bit of weakness or a bit of blurry vision. And a lot of times people will assess that, oh, that's due to something else. I'm tired, or I slept in a funny position and I've been, my arm is kind of numb. Feeling dizzy is often one of the big ones, because there's so many causes of dizziness. And a big cause of stroke is strokes that go to the back of the brain, to the center that controls our balance. And very often, all of us have probably felt dizzy at some point in our lives, and it could be from something you eat, or it could be from a stroke. And then people don't want to get scared and have the mind go off into those negative places. Oh my gosh, I'm having a stroke. Let me just assume I ate something funny. So it's important to take these things seriously.
And certainly err on the side of caution. Along those lines, also another question, is memory loss or changes in personality a symptom of stroke, or is it more common after you've had a stroke?
Yeah, so that's I'll clarify that for you a little bit. It's usually not the sign of an acute stroke, right? When we're thinking of an acute episode happening, someone either has an abrupt blockage of blood flow or a big bleed. So the symptoms will be more focal, or if it's really severe, very severe, right? Debilitating type of symptoms. Patients that have either what's called small vessel injury very often can have, over time, these really, really tiny subtle strokes that we don't even discover until years later, right? Because they just go on progressively, and then family members will bring them to a neurologist in an outpatient setting and be like, I don't think my family member's behaving like they normally do. And then we'll get an MRI and see that this has been going on. And that can be definitely associated with stroke-like episodes. Sometimes they could have an injury to a part of the brain that controls personality. But if it's an acute injury, like I had mentioned, it would usually come with something else. But what often happens is, and not everyone appreciates this, patients can recover from stroke, often very well. But, someone might be weak, let's say on the left side of their body, because they had a stroke to the right side of their brain. A lot of the personality components are over there. And then they just never were the same person anymore. And often families are frustrated by that. And patients are frustrated by that, or, they're performing on a certain cognitive level for years, and all of a sudden they had a stroke and they're not able to do the jobs that they used to do, or the activities that they used to do. And they don't know why, because everything else is fine. So that can certainly happen. And then in the bleeding types of strokes, that also happens because, we mentioned briefly during that presentation about the front of the brain, a lot of big bleeds, even if it could be a traumatic bleed, forget a stroke, just any kind of injury to the brain. If it causes injury to those centers, can cause changes in personality, but usually that's the long term. It's not the immediate.
Dr. Rajah, I want to kind of leap off of something that Dr. Rosenbaum just mentioned in terms of recovery as possible from stroke. So when a patient arrives at Munson Medical Center and you're doing an assessment, sometimes there is a score attributed to a patient based on severity. Can you talk a little bit about that assessment and what it means in terms of chances for a full recovery?
Sure. There's quite a few scales that we use. When someone's brought in, we quickly kind of figure out what is their baseline, meaning, how functionable, what were they doing before the stroke? Because sometimes there's things that look like a stroke but aren't a stroke. And maybe it was just something that had been, going on for years, or was an old stroke symptom or something like that. So we look at that. And then we use what's called the National Institute of Health Stroke Severity Score, the NIH stroke scale, essentially, and sort of grade the level of stroke, where a higher number, up to essentially 42 is the highest. No one really has a 42 because that's symptoms on both sides. It's pretty rare, but really anything above 10, we start to say is a very severe stroke. And we go through and grade different neurological things on the patient with points. Can be points from 1 to 4 essentially, and say, this is how severe the stroke is. And then they're given a number, which is called their NIH stroke score number. And we sort of follow that throughout their hospital stay. And then again, we look at it sort of in follow-up as well. And we also look at something called a modified Rankin score, which then we compare to what their baseline was when they came in. And then we look at it at 90 days when they see us in the clinic, or any of our neurology providers in the clinic. We look at their 90-day MRS score as well. So there's a lot of scoring that goes into it. And there's a completely different set of scores that we use, Fisher scale and Hunt and Hess scores for ruptured aneurysms or ICHs, intracerebral hemorrhage, or hemorrhagic stroke. So it really, there's a lot that goes into the care of both types of stroke patients.
Dr. Rajah, you touched on the number of procedures that have been performed over the last 2 years, and also the number of conditions that can now be treated through Munson Healthcare. Can you, in terms of who is at most risk from I guess a demographic standpoint, an age standpoint, who is at the highest risk for a stroke? And are we seeing either any regional or national trends of maybe that demographic skewing younger?
Sure. I think that's a good question. I can tell you that stroke is typically thought of as an older individual's disease process, but that's not to say that children can't have strokes. They do. That's not to say that young adults can't have strokes. They do. And that the very elderly can't have strokes. They absolutely do as well. And so there's, within each subset of age, from the very young to the typical, more average stroke patient, which is around probably 60 to 70. I think for us, our average that we take, to surgery, the age is around 72. Those, if you look at the very young and the very old, there's different risk factors that go into why they're having the stroke, right? Because, by and large, young children, they aren't smoking, they don't have an unhealthy lifestyle. So there's different genetic issues going on, and conditions that we look into for stroke in the young and stroke in the old. So, anyone can have a stroke, unfortunately. The stroke we think of, again, the ischemic stroke, is that everyone thinks of is more common in the 6th and 7th decade of life. So.
And Dr. Rosenbaum-HaLevi, want to finish up with one question for you. In terms of stroke risk, which is a greater contributing factor, heredity or behaviors?
Well, it's a tough question. If you're going to look at globally all the strokes and lump them into one basket, arguably behavior, right? Because as we discussed in the presentation, a very large percentage of the strokes that we see are potentially avoidable with lifestyle modification and medical management. It's a more complicated question because the genetics that are responsible for stroke, we say stroke, it's a broad umbrella. So there's, and even when we break it down into the strokes that are blockages versus bleeds, that's very gross generalization, right? There are different causes of a bleeding stroke. Could it be an aneurysm? Is it a fistula? Those kind of strokes are much more genetically related, but it's something that, for example, just atherosclerosis in the blood vessels of the brain, probably more lifestyle. So to discount one versus the other is probably incorrect. I think that, yes, for sure, the lifestyle as a whole is probably more responsible, and then it's probably responsible as well for us seeing higher incidences of stroke in the population over time, just with the way people live their lives in the US. As far as mitigating those factors, we spoke about lifestyle modifications, genetics, it's still up in the air. You know, there's a lot of research that goes into this, the significance of having a family member, you know, so again, something like an aneurysm that's taken into account. If we're going to decide, is this an aneurysm that we're going to treat or not? So you say, well, you know, certain aneurysms, it's unquestionable, we're going to treat it. Certain aneurysms, you say, well, and then when your family had an aneurysm that ruptured before, because that increases your risk, you know, and the fact that a child of someone who had an aneurysm makes sense because they have a genetic predisposition for weakness in their blood vessels. But at this point, I don't know how much in the outpatient setting, for example, there's genetic testing going on for screening or anything like that. I don't think that's standard of care at this point. In younger folks, it's certainly a stronger factor. You know, a lot of the reasons that young people have strokes, people, when I say young, I mean under the age of 40, are related to blood clotting disorders, you know, and hypercoagulability, homocystinuria, you know, high levels of cysteine in the blood, all sorts of different, sickle cell, for example, you know, that's a very clear genetic cause of stroke in young people. So then yes, for sure, genetics outweighs. But again, general population, it's the lifestyle. So it's your average person on the street. The advice is don't worry about your genetics. Just live a healthy life and you should be fine.
Dr. Rajah, Dr. Rosenbaum-HaLevi, thanks for all the incredible work that you and your teams are doing for the communities here in Northern Michigan. And especially thank you for taking some time out of your schedule to join us today. It's much appreciated.
Absolutely.
Pleasure. Thank
And
you.
we'll go to the final slide here. Plenty of ways that you can stay connected to Munson Healthcare, get more information about stroke and other health services. You can sign up for our newsletter, follow us on social media, visit us at munsonhealthcare.org, or call the Ask a Nurse hotline at 231-935-0951. And of course, the big thing to remember walking away from this, we just talked about lifestyle choices, but also be fast. If someone you know or yourself is having symptoms of a stroke, please call 911 right away. Thank you for joining us today. And until next time, be well and enjoy the rest of your day.